What if the pill you trusted this morning is not just easing your pain, calming your stomach, or clearing your nose, but quietly placing extra strain on your heart? That is not a dramatic question. It is a question I want every older adult to take seriously. Because after decades in cardiac care, I can tell you this with complete honesty. I have seen people come into the hospital thinking they were doing everything right, only to discover that one of the most familiar items in their medicine cabinet was adding risk they never saw coming. I'm Dr. Caleb Rowan, and today I want to walk you through 5 very common categories of medications and supplements that may increase cardiovascular risk in older adults, especially after age 60, and what you can do about it safely. Stay with me to the end, because the most important part of this conversation is not the warning itself. It is how to protect your heart without making the dangerous mistake of stopping a medication on your own. Before we talk about the medications, we need to talk about why the same drug that seems manageable at 40 can become a very different story at 65, 70, or 80. The aging heart is not necessarily a weak heart, but it is a less forgiving one. Blood vessels gradually become stiffer, blood pressure becomes more sensitive to changes in fluid balance, stress hormones, and medication effects. The kidneys, which help clear many drugs and regulate salt and water, often do not work with the same reserve they had years earlier. On top of that, many older adults are living with high blood pressure, diabetes, coronary artery disease, atrial fibrillation, mild kidney dysfunction, or early heart failure, sometimes without fully realizing how vulnerable that combination makes them. So when I say a medication can become risky, I do not mean the medication is evil or that it should never be used. Medicine is almost never that simple. The real issue is fit, the right medication for the right person, at the right dose, for the right length of time, with the right monitoring. That is how safe prescribing works. Problems start when a drug that was meant for short-term use becomes a daily habit, when over-the-counter products are treated as harmless, or when no one steps back to look at the full picture. And the first category on this list is exactly the kind of medication nearly every household has within reach. I'm talking about nonsteroidal anti-inflammatory drugs, or NSAIDs, ibuprofen, naproxen, diclofenac. These are the pills people reach for when the knees ache, when the lower back tightens up, when arthritis flares, when gardening or walking, or even getting out of bed becomes uncomfortable. And to be fair, they can work well. That is why they are so popular. But in older adults, especially those with high blood pressure, kidney disease, or any degree of heart weakness, regular NSAID use can quietly push the cardiovascular system in the wrong direction. I remember a man in his early 70s who loved working in his yard. He had chronic knee pain and treated it the way many people do: a couple of pain pills here, a couple more there, then a steady routine, because it helped him stay active. He did not think of it as dangerous. He thought of it as practical. But over time, he became more short of breath. His shoes felt tighter by afternoon, his energy dropped. One day, the swelling in his ankles became impossible to ignore, and he ended up in the emergency room with worsening heart failure. What changed was not that he suddenly developed a brand new heart disease. What changed was the stress load his body had been carrying. Here is what many people do not realize. NSAIDs block enzymes involved in inflammation, but in doing that, they also interfere with protective substances called prostaglandins. Those substances help maintain blood flow to the kidneys and help regulate how the body handles sodium and water. When that system gets disrupted, the body can hold on to extra salt and fluid, and when fluid builds up, the heart has to pump against a heavier volume load. For a younger person with a healthy cardiovascular system, that burden may be tolerated. For an older adult with stiff arteries, elevated blood pressure, or reduced cardiac reserve, that extra strain can become a real problem. NSAIDs can also raise blood pressure by narrowing blood vessels and reducing the effectiveness of some blood pressure medications. So someone who thinks their hypertension is under control may suddenly find their numbers climbing without understanding why. The risk is not the same for every drug or every dose. Higher doses and longer use generally raise concern more than occasional, limited use. Diclofenac has drawn particular attention in cardiovascular safety discussions. High-dose ibuprofen can also be problematic. And if you take low-dose aspirin for heart protection, ibuprofen may interfere with some of aspirin's antiplatelet benefit when taken at the wrong time. That does not mean every older adult must avoid NSAIDs forever. It means they should never be treated casually. If you need them, the principle is simple: the lowest effective dose for the shortest possible time. In some cases, acetaminophen may be a better option for pain, depending on the situation. In other cases, topical anti-inflammatory gels or creams can target sore joints with less whole-body exposure. Physical therapy, heat, weight reduction, better footwear, and strength work may reduce reliance on pain pills altogether. The key is not to silently slide into daily long-term use without a conversation. If you are over 60 and you find yourself reaching for ibuprofen or naproxen several times a week, that alone is worth bringing up with your doctor. The next category is one that surprises many people because it is often prescribed with good intentions and is widely viewed as protective. I'm talking about proton pump inhibitors, or PPIs, omeprazole, pantoprazole, lansoprazole. These drugs can be very helpful for acid reflux, stomach ulcers, and protecting the stomach in certain high-risk situations. Used appropriately, they absolutely have a place in medicine. But the problem begins when short-term therapy quietly turns into years of uninterrupted use with no reevaluation. I think of a woman in her late 60s who started a stomach acid medication for chronic reflux. It worked quickly, so no one questioned it again. Years passed. Then, during a routine evaluation, she was found to have an abnormal heart rhythm. Further testing showed one important clue. Her magnesium level was low. Magnesium matters because it helps stabilize the electrical system of the heart. When magnesium drops too far, the heart can become more irritable, more prone to rhythm disturbances, and in some cases, dangerously unstable. Long-term acid suppression can reduce the absorption of magnesium in certain people. Not everyone on a PPI develops this problem, and I want to be very clear about that. This is not a reason for panic, but it is a reason for respect, especially when someone has been on one of these medications far longer than the original plan. There is another reason for caution. Some PPIs, particularly omeprazole, may interact with clopidogrel, a medication used to help prevent blood clots after certain cardiac events or procedures. That interaction does not apply equally to every acid-suppressing drug, but it is one more reminder that even familiar medications can have consequences beyond the symptom they treat. You may also hear claims online that PPIs directly cause heart attacks. That conclusion is stronger than the evidence allows. Some studies have found associations, but association is not the same thing as proof. What I am saying is simpler and more reliable. If you are on long-term PPI therapy, especially as an older adult, it is reasonable to ask whether you still need it, whether the dose can be reduced, whether another strategy might work, and whether monitoring magnesium makes sense in your case. Sometimes reflux improves with weight loss, earlier dinners, less alcohol, smaller meals, and elevating the head of the bed. Sometimes a step-down approach is possible. Sometimes long-term treatment is still the right choice. The right answer is individualized, not automatic. Now let's talk about a medication people often do not even think of as a real cardiovascular issue because they buy it at the pharmacy for a cold. Oral decongestants. Most commonly, pseudoephedrine, and sometimes phenylephrine in cold and flu products. If you have ever been miserable with nasal congestion, I understand the appeal. When you cannot breathe through your nose, sleep is poor, your head feels heavy, and you just want relief fast. That is exactly why these products sell so well. But what clears the nose can also challenge the heart. A retired school teacher I once cared for took a decongestant for a bad cold because she wanted to breathe better at night. Within a short time, she felt pounding in her chest, a severe headache, and intense dizziness. In the hospital, her blood pressure was dangerously elevated, and her heart rhythm was unstable. She did not take the medication recklessly. She took it the way many people do, assuming that if it is sold over the counter, it must be harmless. But oral decongestants work by constricting blood vessels. That is how they reduce swelling in the nasal passages. The problem is they do not stay politely limited to the nose. Once in the bloodstream, they can tighten vessels throughout the body, increasing resistance and pushing blood pressure higher. They can also stimulate the heart, leading to palpitations, a faster pulse, and in vulnerable individuals, rhythm disturbances. If you already have hypertension, coronary artery disease, atrial fibrillation, heart failure, or a history of stroke, that extra pressure may not be something your body handles gracefully. And because these are cold medicines, people often combine them with caffeine, poor sleep, dehydration, and other stressors that make the effect even less predictable. For older adults, especially over 60, oral decongestants deserve real caution. Safer approaches may include saline nasal spray, humidified air, warm showers, hydration, or in some cases, a locally acting nasal spray recommended by your clinician. The point is not to suffer through congestion unnecessarily. The point is to avoid turning a temporary stuffy nose into a cardiovascular emergency because the label looked routine. The fourth category is more sensitive, because it sits at the intersection of mental health, chronic pain, and aging. I'm talking about older tricyclic antidepressants, such as amitriptyline and imipramine. These drugs are not used only for depression. They are sometimes prescribed at low doses for chronic nerve pain, migraine prevention, or sleep-related complaints. And I want to say something important here. Depression matters. Chronic pain matters. Treating them matters. The goal is never to minimize suffering. The goal is to choose treatment in a way that protects the whole person, including the heart and the risk of falls. I once cared for an older man with diabetic nerve pain in his feet. A low-dose tricyclic helped with the burning discomfort, but soon he began feeling lightheaded whenever he stood up. One day he fainted, fell, and fractured his hip. In a younger person, dizziness might be an inconvenience. In an older adult, it can be the beginning of a cascade. Fracture, hospitalization, loss of mobility, loss of independence, and a long recovery that changes everything about daily life. Tricyclic antidepressants can lower blood pressure when you stand, a problem called orthostatic hypotension. They can also increase heart rate and affect the heart's conduction system, which is the electrical wiring that coordinates each beat. In some patients, especially those with existing heart disease, electrolyte problems, or multiple medications, they can increase the risk of abnormal rhythms. That does not mean these medications are never appropriate. It means they are no longer the easiest or safest default for many older adults, particularly when newer options may be better tolerated. If you are taking one of these drugs for depression, nerve pain, or sleep, do not stop it on your own. But do ask whether it remains the best fit for your age, your blood pressure, your heart rhythm history, and your fall risk. Sometimes the answer will still be yes. Sometimes there is a safer alternative. What matters is that the question gets asked before a fall or rhythm issue asks it for you. The final category is the most controversial on this list because the science is more nuanced, and that is exactly why we need to talk about it carefully. Calcium supplements. For years, the message to older adults, especially women concerned about osteoporosis, was straightforward. Take calcium to protect your bones, and bone health absolutely matters. A hip fracture in later life can be devastating. But the conversation has evolved. Researchers have asked whether concentrated calcium supplements may affect the cardiovascular system differently than calcium from food. Here is the concern in plain English. When calcium comes from food, it is usually absorbed more gradually as part of a meal, alongside protein, fat, and other minerals. When calcium comes as a pill, especially in larger doses, it may create a sharper, temporary rise in blood calcium levels. Some researchers have proposed that repeated spikes could contribute, in certain people, to vascular calcification, the buildup of calcium in artery walls, and if arteries become stiffer and more calcified over time, that may contribute to plaque-related disease. That theory is biologically plausible, but plausible is not the same as settled. The evidence here is mixed. Some studies and meta-analyses have suggested a possible increase in heart attack risk with calcium supplements. Others have not found a clear, harmful effect. So I do not want to overstate the case. I do not want you leaving this conversation thinking calcium pills are poison. They are not. Some people with documented osteoporosis or inadequate dietary intake may still benefit from supplementation as part of a broader bone health plan. But what I do want is a more mature, individualized conversation. If you are taking calcium on your own because it feels like the healthy thing to do, pause and ask whether you actually need it, how much you are already getting from food, and whether the dose makes sense. Many adults can support bone health through food sources such as dairy, yogurt, kefir, fortified foods, tofu made with calcium, sardines with bones, and leafy greens, while also addressing vitamin D status, strength training, balance work, and fall prevention. Calcium is not just about what you swallow, it is about the whole system that keeps bones strong and people upright. Supplements may still have a role, but they should be used with intention, not assumption. Now, after hearing all of this, there is one mistake I do not want you to make. I do not want you to open your medicine cabinet and start stopping things out of fear. That can be just as dangerous as taking the wrong medication too casually. The real goal is not panic. The goal is a medication review, a thoughtful reset, a clearer understanding of what is helping you, what may be adding risk, and what needs closer monitoring. Before your next medical visit, do something simple but incredibly powerful. Make a complete list of everything you take, not just prescriptions. Include over-the-counter pain relievers, cold medicines, acid reducers, vitamins, supplements, sleep aids, and anything you use only occasionally. Bring the actual bottles if you can. This kind of brown bag review is one of the best ways to uncover duplication, unnecessary long-term use, and hidden interactions. Then ask direct questions. Is this still the safest option for me, given my age and heart history? Could I use a lower dose or for a shorter period of time? Is there an alternative that places less stress on my blood pressure, fluid balance, kidneys, or heart rhythm? Do I need monitoring, such as kidney function, magnesium, blood pressure checks, or an EKG? Could this medication interfere with my aspirin, my blood thinner, my blood pressure treatment, or another drug I take every day? These are not difficult questions. They are smart questions. And smart questions protect people. I also want you to respect early warning signs: new ankle swelling, unusual shortness of breath, chest pressure, palpitations, lightheadedness when standing, a blood pressure reading that suddenly runs higher than usual, a sense that your stamina has changed for no clear reason. None of those automatically means a medication is to blame, but all of them deserve attention, especially if they appear after starting, increasing, or regularly relying on a drug that seemed harmless. If there is one big message I hope stays with you, it is this: familiar does not always mean safe for everyone, especially later in life. A pain pill, a reflux medicine, a decongestant, a nerve pain tablet, or even a supplement can behave differently in a 70-year-old body than in a 40-year-old one. That is not failure. That is physiology. And understanding that gives you power. Your heart has carried you through stress, grief, work, family, illness, recovery, and years of ordinary life that matter more than people realize. It deserves care that is deliberate, not automatic. It deserves medication decisions made with context, not habit, and it deserves a doctor-patient conversation that is honest enough to ask not only, does this help my symptom, but also, what is this doing to the rest of me? If something in this video surprised you, tell me in the comments. I read them, and your experience may help someone else ask an important question. Share this with a parent, a spouse, a sibling, or a friend over 60 who keeps a few too many routine medications in the cabinet. And if you are serious about protecting your heart as you age, make one commitment today. At your next appointment, review every medication and supplement with your doctor or pharmacist. One careful conversation, at the right time, can change the direction of your health more than most people realize. Thank you for spending this time with me. Take good care of yourself, protect that heart with intention, and I'll see you in the next video.